All right, so I'm joined by Dr. Blake Bloxham, a renowned expert in hair restoration and a close friend of mine, who performed my own hair transplant. With his years of experience and dedication to providing the best techniques for each individual, Dr. Bloxham has helped countless people achieve life-changing results. Beyond his surgical expertise, he's also an educator and a consultant, and I'm excited to share that he and his expert team are joining Main and Steel. Together, they'll be offering on-site treatments here in Newport Beach, California, New York, St. Louis, Philadelphia, and Fort Lauderdale. I started Main and Steel to provide the best evidence-backed solutions for hair loss, including oral Dutasteride monotherapy, combination with oral minoxidil, as well as topical Dutasteride with minoxidil. In collaboration with Dr. Bloxham, we'll also be offering injectable Dutasteride mesotherapy paired with advanced growth factor treatments from CTM Biomedical. In addition to hair loss, we offer comprehensive treatment protocols, including peptide therapy, weight loss, GLP-1s, and sexual performance enhancement. One aspect of our mission is to help stop hair loss and to maintain a powerful community of like-minded men that cultivates strength and confidence through innovative treatment solutions. So Blake, thanks for flying all the way in from New York, luckily for a weekend.
I was here.
Your brother's getting married. So give me why, so you go to med school, why hair transplants versus like surgery or internal medicine?
Yeah, so I'm one of the weird ones. Most of the doctors that you see in the hair transplant field, they're guys that did something else for a while. You know, it could be peripherally related, like dermatology or surgery. It could be something completely, out of the blue. One of my partners was in radiology before he went into this. Another one was in emergency medicine. But I was one of the weird ones, and this is why I look younger than some other guys in the field. I went basically to med school to do this.
Yeah.
When I was a pre-med, I did my pre-med studies at UCLA out here, where I'm originally from, is Orange County, where we are today. And I liked like aesthetic and cosmetic stuff. It's just something about it was just very interesting to me. And I had no idea what hair transplant was. Didn't even really equate like hair restoration with cosmetic surgery. But when I was in college, my grandmother had a little bit of like a breast cancer scare. And she's fine, everything went well, but when she was, sort of facing this, one of the potential side effects of the medications that the oncologist warned her about was hair loss. And she was very concerned about that. This was one of the first times when I really started to sort of comprehend, or I was at least faced with like the psychology of hair loss. It was just fascinating because she was facing all of this potential very serious, life-altering stuff. And the hair loss to her was just such a big deal. And even though it was a big deal, she didn't feel like she could bring it up with the oncologist, like what she could do to prevent it, what she was looking at there, because she just didn't feel like it was important. This is a cancer doctor. So she asked me, because I was a pre-med, and I said, I don't know. I know nothing about hair loss, but I'm like, I'll do some research. So I did some research for her, actually ended up recommending a few things, and she was actually good. She really didn't lose much hair at all, and she's maintained it with a few things I recommended. But in doing that research, I just learned, all about the biochemistry, the genetics, the science of hair and hair loss. I just thought it was fascinating. And then doing that same research, I found out about hair transplant surgery. And I'm like, okay, this is all just kind of coming together. So decided I wanted to do hair transplants. I was lucky to be able to work with some groups before I was really even in med school and in med school that put me in a position to network with some doctors. And one of the doctors that I reached out to, because he was just really successful, I really liked his philosophy, and he seemed really cool, was Dr. Alan Feller, my partner in New York. And some doctors I reached out to, and they were like, no, I don't really want to bring on students. I don't want to, train people. And he was like, come on in. Anyone can come in and watch what I do. He's super open and transparent about it. So started, just kind of shadowing him basically, and a few others, including Dr. Meshkin in Orange County. He was awesome. He was probably the first hair transplant I ever watched was Dr. Meshkin's office. Great guy. But started spending a lot of time with Alan Feller out in New York, and eventually I got to the point where I was doing my postgraduate work, which you need to be licensed. And I was kind of formally training with him. And the initial plan was to come back here to Orange County and open up practice here. And he was like, look, I've been doing this for a long time. I've been looking to bring someone on and kind of, take over the reins here. He's like, this is in motion, just, do this here. So that was very hard to pass up. So I took over from him, and that was like 10 years ago now. So I had a very direct path into it, which is why I look, I think, a little younger than some of the other doctors
youngest
in the field.
looking hair transplant
maybe not the youngest
surgeon.
looking, but
So you kind of got into the throes of it too when you were doing monitoring on Hair Restoration Network,
yes,
right?
Yeah.
So what did you kind of learn from that? Especially kind of being in the depths of the, let's say, the psychological aspects for hair loss in men who they're looking to go for, and it kind of gave you an idea of what the funnel was to getting a hair transplant?
Yeah. So the time there was obviously great, and I did learn a lot. One of the things that you learn, I was a moderator there, and created a lot of content for them. And this was like 2000, and I worked there like 2009 to 2000, maybe 2009 to 14 or 2010 to 15. So this was before like AI, obviously. So I mean, this content, like I was in the trenches there writing the content. And so I learned a lot more about the science of hair loss because I was creating this content for the site. I also learned, like you said, a lot of the sort of the psychology, and I don't mean that as like a dirty word or anything, the psychology, but there is a lot of psychology on both sides of it. There's psychologies from the doctor's point of view, psychology from the patient's point of view. So I learned a lot about that. I learned a lot about what patients, I think, are looking for, things they like, things they don't like in a doctor. And I also think I learned a lot about, what you as a patient want to look for in a doctor. Because, as the internet continued to sort of grow and evolve, I think it became harder for people that were just big on the splashy, flashy marketing, which worked, back in the day. Yep. Especially, before the days of the internet. There were people that were just objectively not doing a good job, but they were marketing through TV infomercials, through, blasting mail ads and stuff like that. And sites like Hair Restoration Network were good at sort of, cutting that away and saying, don't focus on this stuff. Look at these guys, look at what they're doing. The founder of it, Pat, even literally drove around to different spots in the country to go visit these guys and say, see how this guy is, look at his results, look at this other guy's results. That's because this guy is using microscopes when he's cutting it down. He's using these little custom cut blades to make the incisions. So it really changed kind of the narrative, and it showed patients like this is what you need to look for in a doctor. And it also, I think, showed sort of cut the wheat from the chaff when it came to there were certain doctors that didn't have a problem going on there and kind of getting in the arena and saying, this is what I do, critique it. Yeah. And there were even some doctors, and I think Dr. Feller was great at it, who had no problem going on there and kind of even going toe to toe with some of these guys because, the internet has always been a place where you've had, some people that like to kind of go on and rile up. You maybe even have some people that are there with bad intentions that are working for other clinics, things like that. He'd never had a problem going toe to toe. And I think that showed patients like, man, this guy has no problem showing what he's doing. These other clinics are saying, oh, I use a specialized, secret tool that you can't know about. These other patients are showing me, there's other doctors, are showing me, results from real, glossy looking photo shoots from 1995. This guy's putting a result on the internet every week. So it really helped kind of educate, I think, which was a very good thing. The internet's continued to evolve, and there's different things that have happened here and there. But I think that was a very, very good thing, and it taught me, getting back to your question, what the patients want to see, how the doctor should be presenting themselves, and what you should strive for as both a patient looking for a doctor and a doctor looking to attract patients by showing your work.
So FUT versus FUE, probably the biggest topic in hair transplant surgery. So let's talk about the differences and their impact. So explain like key differences, FUT versus FUE. If you're on this channel, you know what these are.
Yeah,
but for layman's terms, give people, in your opinion, what are the main advantages, disadvantages, and just a brief excerpt on which each one is.
Okay, absolutely. So, it's a topic that's been covered many, many times. It's a very controversial topic. If you drop this in a forum somewhere, it's immediately going to be a powder keg. It's probably not as bad now as it was like 5-8 years ago. But my God, I mean, there was no easier way to stir up, kick up controversy, make a moderator's job harder than start one of these FUT versus F3 threads. But the advantages and disadvantages of both. First, I think it's important to acknowledge that there are advantages and disadvantages to both. And I also think it's important for patients, even if you're convinced that you want to go one route versus the other, I really advise seeing a doctor that can do both. I think it's very tempting to say, this guy only does one surgery, he's the expert at it, I know I want that surgery, so let's go to him. But I think it's important to get a perspective from someone who does both, because it's going to help you understand what you might be better or worse suited for. But as far as the advantages and disadvantages, so starting with FUT. So the advantage of FUT, or advantages off the bat, number one, in my opinion, is graft number. FUT, you can achieve high graft numbers with both, and we'll get into that in a moment. But with FUT, I think you have a much greater chance of hitting your quota graft numbers, because it's you're always going to reliably get those grafts out. Your estimate may be a little bit off. It's impossible. Like when I did your surgery, I think you told me earlier, I quoted you about 25. We ended up with 24, 170,
24, 17.
So I can never tell exactly how many I'm going to get. So there's always going to be a little bit of an estimate and a little difference there. But I've told you 25. We got roughly 25. When you quote someone with an FUE, it's never quite as clear because you're never certain how those grafts are going to come out. But with FUT, you're taking them out in one segment, you're going to get, those quoted numbers. So there's always a little bit more certainty there, number one. Number two, I firmly believe, and I do a lot of both surgeries, and I think I'm very good at doing both surgeries, but I firmly believe that FUT grafts grow better. And we'll get into that in a little bit, but I think you're going to have a higher growth yield with FUT compared to FUE. Studies have shown that FUT consistently grows. Some studies have shown like 95, 98% yield. So for every 100 grafts you move as an FUT, 95, 90 of them are going to grow. Other studies, Dr. Biener out of New York, who's done a lot of great studies, he showed that it may be a little bit lower for both. I think his estimate for FUT or his result showed still 90%, so still great yield on average. So that yield is going to be higher. Another sort of under-discussed aspect about FUT where it really shines and is an advantage is donor management. Donor management is a phrase that's thrown around online a lot, but it's almost always in regard to FUE. But FUT is always just going to clean the clock when it comes to donor management because FUT is super efficient. With FUT, it's really efficient because you're not reducing something called global donor density. So that means the entire density of your donor area. Global donor density can only fall below a certain point before it looks bad and you're basically done back there. And FUT doesn't change that because with FUT, of course, you're taking hair. You're taking it all in one segment, but you're also reducing the area, like the skin that you take. So when you take hair and skin and you reduce it down, it's pretty much unchanged. If you had this amount of surface area, this amount of hair, and you took the equivalent of both, it's unchanged. So what it means is that you can take out a lot of grafts and you can pick and take them, in most patients, you can take them from the best location where you're going to have just the awesome, perfect, what they call like a gold, I call it like the golden spot or something like that. That you're going to get about the best grafts, and because you're reducing that area, you're still leaving everything in really good shape. You're being very efficient with the harvesting. You can go back in after that's done. You can do more FUT, because everything is untouched. If you did one strip and you're like, I don't want to do that, or I switched to FUE, you haven't changed the density, so you can still go in and do an FUE at basically the same level that you would before. So it's very efficient. And it also leaves the donor in great shape for future surgery. So you have a very, very high certainty, almost a guarantee that you can go in and do more surgery after you've done FUT. So that's very good for patients that have advanced hair loss, and you're going to need to use that donor as efficiently as possible. It's also very good for young patients because you have no idea what the future is going to hold for young patients. So I would say those are some of the big advantages of FUT. The obvious disadvantage, and I don't even like calling it this, but we will. The obvious disadvantage of FUT is the difference in scarring. FUT is going to leave a linear scar in the donor area.
Which can be hidden a lot easier.
It can be hidden, but it is going to leave a linear scar in the donor area, and I understand why that sets off some alarm bells for some patients. It's we can vary the scar in length, but a lot of times it's a long scar, and I always try to have that conversation with patients. Is we could do a shorter scar, could do a longer scar, but there is going to be a linear scar back there. Typically they heal up, quite thin. I typically tell patients our average scar is anywhere between like a pencil line if you're a perfect healer, up to maybe a marker line, which is like 3 millimeters or so of stretch if you're a little bit of a natural stretcher. And all that, like you said, can be hidden even with short hair, like a number 3 on the buzzer. But if you decide in the future that you want to really shave it short, there's a linear scar. There's no two ways about it. It is a trickier scar to hide when it comes to the comparison between FUE and FUT. So that linear scar is probably going to be considered the biggest disadvantage. I think what you get for that linear scar is great, but that is the disadvantage. Yep. So as far as switching gears to FUE, so the advantages of FUE, the biggest advantage of FUE is that it is going to leave different scarring in the donor. FUE is not a scarless procedure. If you are watching this video and you go see a doctor and he tells you it's scarless, shave your head if you don't like it, turn and run. I'm sorry if that sounds harsh, but do it because it is a scarring procedure. There's no question. There's no way to cut the skin as of right now. without leaving some level of scarring. But FUE leaves small, less than 1 millimeter, should be less than 1 millimeter dot scars. And if you do a small enough number of those and you spread them out throughout the donor area, scarring can be wonderful from FUE. Just absolutely great. It can be. One of the other advantages of FUE is that it does allow you to sort of bounce around a little bit, obviously. So with FUT works really well if you have a patient where all of their good stuff is in its sweet spot. I was calling it the golden spot, whatever, it's sweet spot. If all of the patient's best stuff is in the very traditional donor area, FUT is great because you can take, from right where that's all concentrated. Some patients, though, have good donor, but it's just more spread out. So I'm not going to take a strip, all over the place. So in those patients, you probably honestly can pick better stuff with FUE. So it's nice to be able to bounce around like that. You also, if you have a kind of a specialized case like a temple point, or if you're just doing hairline or something like that, you can select certain grafts. I'm not always a huge fan of that like cherry picking narrative, but you can do that. So it's an advantage there. It's also an advantage because it allows you to access grafts from other areas, which I think is a very long conversation to have somewhere else. But obviously, if you're a patient that needs like some beard grafts, chest grafts, something like that, FUE allows you to do that. You're not going to take a strip from here. I hope you're not going to. Yes, like I said, FUE is good about letting you access parts of the donor that you typically can't with FUT. Remember, you can do an FUT first and then an FUE to access it, but it's very good at that. It's going to create very subtle scarring back there if done appropriately. If you go get one of these, 5,000-6,000, blast out the back, you're in a bad position regardless in the back there. But if you do it appropriately, it's going to allow you to wear it shorter back there and have some really subtle scarring. It's hard to pick up on. It allows you to utilize hair from other spots of the body. A couple of the disadvantages of FUE. The number one is, again, I firmly believe it doesn't grow as well, and we can get to that in a minute. But I just don't. I do a lot of it. I would have no problem sitting next to any of these really big names in FUE and showing them what I do and comparing it to what they do, and I think it would be very, very similar. But it does have a lower growth yield, and we'll get into that in a moment. But it just, in my opinion, in my experience, it just doesn't grow as well. It's much more variable, which you get with the growth. So I think growth yields less with FUE. And I also think, again, something that's just not talked about enough online is the donor management with FUE is trickier because of that phrase I mentioned before, that global donor density. With FUE, you're removing hair, but you're just leaving that spot open. So it reduces the density, and you can only do that so much. Estimates vary, but somewhere between 30 to 50%. You can only drop that before you really have a problem back there and it looks bad. So it always didn't reduce that density. So it's just not as efficient back there. You can't do as much as with FUE alone as you can with FUT than FUE. So you have to be careful about that. So I would say the big disadvantages are the donor management is not as good, and the growth, in my opinion, isn't as good either.
Dr. Feller always says you can hide the FUT scar
even
a lot
a bad
easier.
strip scar. Yeah.
Well, and I think FUE, it's like, having 3 transplants myself, I'll talk about those, is I can spot guys very quickly who have had FUT, barely see it. Only my eye can spot that, I know. Yeah. Versus FUE, where moth-eaten, where it's like you're taking a strip of duct tape and then you're pulling it. That's what it looks like. And even when you grow it out, it looks worse.
The density's gone.
Exactly, because the density's gone. So it's individual, right? So you could have someone coming in and needs 1,800 grafts, and they're like, I really want to use FUE, and I think you could get away with that depending on their donor. But for myself, I'll post photos too. Like I was like completely going like bald. You've seen mine. And
I don't think I saw those initial photos until recently. But I was like, wow, you were
and like
really restored nicely.
Yeah, we'll and I still got one more. We're gonna keep filling this in to make it better. But like my first experience, I got sold into marketing. I don't want to badmouth anyone. I'll say this. I got sold into the marketing of a hair transplant, FUE, no scar, all that stuff. I was uneducated myself. I wasn't on the Hair Restoration Network. This is in 2019, leaving Florida, coming to LA, living in all of it, and being like, oh, wow, who am I going to go to? Yeah. I didn't do enough interviews. I didn't get enough information on the Hair Restoration Network. Shout out to Melvin. Went into it blind, paid way too much. The results were crap. It was FUE targeting, 25 to 3,000 with PRP, which we'll talk about, which I think destroyed the donor region doing PRP prior, like literally the day of. Not enough care was taken on myself. I don't blame the surgeon. I blame myself for not choosing what was appropriate for me and not knowing enough about FUT. And then that's when I switched. You and I hadn't formed yet a relationship. I moved to Orange County And literally across the street from where I live is Dr. Meshkin. And I see Dr. Meshkin hair restoration, and it was kind of like blind fate, you know. It was something that happened where I was like, I'll just go over here and see this guy. And Dr. Meshkin was so educated. First thing he does, he puts his book on the table and shows me, but so educated, so nice. And I read the reviews, and you know, he really said, we can do FUT on you. It's totally fine. And he did such a great job in helping get coverage. He did 2,500, and I got like so much great coverage to like the crown,
he's very good at that.
the strip. Like when you were looking for the strip on my third surgery, we could barely even find it.
It took me forever to find, because I always like to, if it's a surgeon that I know they took the strip from the right case or the right location, excuse me, I always use their line so I don't create a second.
Exactly.
And it was hard. It took me like 20 minutes to
shout out to Dr.
map that.
Meshkin. Yeah, you did an incredible job. And I would say the whole procedure was just like the FUT it's more efficient is in terms of speed and you being on the table. The FUE, oh my God, like sitting there, my back was going out. I'm just like trying to move, but like I don't even remember the strip with Dr. Meshkin. You know, he has a different method. He laid me down, and I think I fell asleep. I felt great. I woke up, and he was like, "All right, it's time to implant." And it was comfortable. It was easy. I have no complaints. The result was great. And then when I saw you, the reason I didn't choose Dr. Meshkin the second time, you know, he quoted me a little bit different on the second strip. And then you and I spoke, and you were, you know, I'm confident I can get higher numbers. And I said, let's do it. And that's when I flew out there, and the result was great. We're going to fill in the crown a little bit more. But like, I was literally like bald. Like, I'll tell everyone. I'll show the photos and show you my experience. Now, I want to talk a little bit more about the FUT stem cell theory you have. And I experienced this myself, where the first surgeon quoted me at this, but yet I don't have the scarring that I should for the amount that he said, like 3,000 or something. It's like weird. My donor still looks great, which is why I switched over to FUT. Tell me more about how FUE may not allow for like the full transfer of the actual stem cells at that follicular level, and kind of elaborate on what your theory is, because we don't know. This is theorized, right?
Yeah, this is something I really haven't seen this talked about much before, but you know, there was something I read a long time ago. I think it was actually Dr. Cole, Dr. John Cole in Atlanta, who said this, and he had said something online where it was like, you know, a hair transplant is actually a stem cell transplant, and it's very true. When we think of a hair transplant, we always talk in terms of grafts, and I think what a lot of patients believe is that, you know, you take out the structure, you put that structure back in, and that's what it is. You know, it would be like if you transplanted an arm to someone else or an eyeball or something like that. That's really not what happens with hair transplants, because that's not how hair follicles exist. Hair follicles exist basically as two sort of discrete areas of stem cells, and they're from different lineages, and these stem cells exist in different parts of the follicle. And the entire cycle of a hair follicle, as far as like the timing of growing the hair, the length of the growing of the hair, when the follicle's active, when it's asleep, is crosstalk between these two areas of stem cells, and likely crosstalk from stem cells surrounding it as well. But without those, you know, stem cells, the whole thing doesn't work. So when we transplant a graft, in there, and immediately what happens is the hair sheds. The reason why is because the graft goes to sleep. Those two areas of stem cells stop talking to each other. And when they do that, when they go into what's called that telogen resting phase, they actually separate, and they sort of rest in different areas. And when they're ready to wake back up, they start talking and they grow, you know, hair. So that's really how hair works. That's really what a hair transplant is moving those two areas of stem cells. So in my opinion, you know, when you do an FUT, you're taking out that entire section, you're putting it under a microscope. If you have good technicians, you can see exactly what, you know, obviously you can't see the stem cells, but you can see, you know, what needs to be left, what can be cut away, and you've got a graft that is as intact as it can be and has the best chance of growing as it can. When you do an FUE, that's simply not the case. So Dr. Feller, to my knowledge, was kind of one of the first guys who was very big in FUE. A lot of times now, if you mention Dr. Feller's name, people will say, oh, he's anti-FUE, he's all pro-script. What's funny is back in the day, he was attacked for the opposite. So he started doing FUE. He's a super bright guy, and he's very much like an engineer and inventor at heart. And he invented he saw FUE, thought this is cool, this is something interesting. So he really, you know, dove into it, invented a lot of different tools and techniques. And in doing so, you know, he started doing this in like 2002. And in doing so, he sort of isolated problems with FUE that he was trying to get around with his tools. And in the end, his conclusion was basically you can't get around them. No matter how good of a tool you make, you can't get around these. But he identified a couple different detrimental forces that he thought were applied to FUE grafts, because there's always more trauma applied to FUE grafts. You know, the twisting, the pinching and
pulling.
pulling. So he identified these detrimental forces and said, the reason why FUEs aren't growing as well is because of these forces. And if you can get around these, you're probably okay. And he thought he minimized them as much as he could with his tools, but never really got around them. So for years, that was kind of my mentality. And he could be right, but that was kind of my mentality, is that it's these forces that, you can't get around. But since then, there have been a lot of doctors that I think have done a good job, particularly Dr. Dubois out of Belgium. His new FUE system, I've used it. I think it's quite good. And I think he very cleverly sort of got around some of these forces. So I think you can make the argument that some of these newer tools, they're not, FUE's FUE, it's spinning a punch around a graft. They're never going to get around that. But I think a lot of these new tools have been, good at reducing those. And I also think that there's always going to be, some level of trauma applied to grafts, like with the placing, the sitting out of the body. So I was thinking to myself, is this really what it is? Is it really just that there's trauma applied to these grafts and it's just never going to be as good? And it's just the physical trauma. But what I started to think about, I sort of harkened back to what Dr. Cole had mentioned about the stem cells. And I'm like, when I look at an FUE graft, and even these guys that are showing their FUE grafts and saying, look at how beautiful these are. When you look at an FUE graft, for whatever reason, a lot of big FUE guys don't like going down very deep. They'll go maybe, the sort of consensus is that if you go down maybe about 2 to 3 millimeters, enough to sort of break away the little muscle attachment, the erector pili muscle, and some of the attachment from the sebaceous, from the oil gland. If you break that, you should be able to free those grafts pretty easily. Now, it's variable in patients, in my opinion, but it's rare that you'll find a guy that likes to go all the way down deep and really, really remove all that tissue. I personally like to. I like to try to, one of the reasons I started sort of using a tool like Dr. Dubois or Dr. Dubois' tools, because it allows you to go really deep. But even then, like if you look at most of the people using his tool, they're still not going down deep. They're still going down about a couple millimeters, and then they're freeing the graft. And I think it's because you get less transection. There's less of a chance of cutting it if you don't go all the way down. But when you look at these grafts, the top portion will look good. The bottom portion always looks what I call skeletonized. So the bulbs are there, and a lot of times people say, hey, there's bulbs, we're good. The bulbs of the follicles are there, but there's less tissue around it. And if you look at the two sections of stem cell activity in a follicle that you need for it to function, the one section is at the kind of the middle, so you're probably getting that going down 2-3 millimeters. The other section is right around the bulb. So I personally believe that when you do an FUE, and 99% of people probably only go down about 2-3 millimeters or so, and then pull it. I think when you pull, you're ripping away a lot of that stem cell tissue from the bottom of it. And because of that, it's just not going to grow. It doesn't matter how gentle you do it. It doesn't matter the type of tools used for implantation. If those, what are called the dermal papilla stem cells at the bottom, if those just aren't there, there's no way for these follicles to, these two areas of stem cell activity in the follicles to talk to each other and to grow normal cycling hair. So my opinion is that because a hair transplant really is a stem cell transplant, you're missing a big portion of stem cells. So you're never going to get hair that's going to grow as well, and a lot of times you're going to get hair that doesn't grow at all, even if it looks good. Even if you're super gentle with everything, if you have just removed those stem cells, and it always happens when you're pulling it, it's just not going to grow. So that's kind of my
hence the reason the FUE does not yield as a quality of hair. Like we're literally pulling away some of the engineering structure of the FUE and FUT, going all the way down to the bottom. I mean, if you look at an FUT surgery, it's pretty gross. I mean, you're going sub-Q, you're getting the fat. You can clearly see the sub-Q fat versus FUE, where it's like, some of these guys online, they post their stuff, and I'm like, how is that even gonna? It's like literally just the hair with a little bit of the follicle. But like when you see FUT, that strip, it looks gross. If you can't stand blood, don't watch them. But to me, it's interesting. It's like, wow, you can see the sub-Q, the yellow sub-Q. That's the juiciness that you want. That, like you said, holds like. And where do we derive stem cells from? We're doing it from the fat, from the sub-Q.
It's funny. My partner from London, who I don't know if I'll mention it or not, but Dr. Priestis from London, he's been in New York with me the past month doing surgeries and hanging out. And he was telling me, because we've done a lot of FUT and a lot of FUE, and he goes, those FUT grafts, he's like, when I look at them when they're on the scalp when the girls are placing, he said, I love it because they glow. And I go, they glow? I go, what are you talking about? And he was referring, like you said, to the juicy, the fat at the bottom, because it's this like juicy golden fat. And he's like, they glow.
It does.
In his great, British accent. He's like, they glow. I'm like, oh my gosh, that's such a funny way of putting it. But I think that's what you're referring to.
Yeah, that's exactly, like you can see it. Go online and look at an FUT graph versus an FUE. It's cleaner too. Like we're slicing so clean the actual scalpel, this steel, made in steel, the steel of the slice is so good and so clean that I mean, and very minimal destruction. Like
There's almost no.
and I think you, Dr. Feller, on your YouTube, go to this, guys, if you can. He has a really good video. I remember the description, like you guys have the paper, and he talks about pulling it apart. Go to their website, Feller and Bloxham YouTube, check it out, and you'll see, like, use the video. I think it's the FUT versus FUE. Older videos, but they're great. Watch all the videos. Dr. Feller is awesome. He's so confident, he's great, but these guys, they show a lot. Talk about, little controversy, discontinuation of PRP injections and how specifically I remember you mentioned about how it's causing active inflammation. We know, it might work well in joints. I personally wouldn't inject in my joints. I wouldn't. I had it on my first FUE, which I believe contributed to the lack of growth with my FUE because I had, it was PRP, which was not my own. It wasn't spun. It was someone else's, which is, again, weird. Yeah, it was not my own.
Oh, wow. Okay.
So, yeah. So spun, usually, PRP comes from your own blood. So it wasn't my own. And then had the surgery right there. So I think that contributed to the lack of growth. I could be totally wrong. But tell me more about, like, many clinics still offer it. Why are you no longer using it? Give people a little bit of the science as to your theories on the inflammation that it actively causes.
So, I don't have any problem publicly stating I'm not a big fan of PRP. I wouldn't completely throw the baby out with the bathwater, but I'm not a big fan of it. I think I said, I don't even, like, even in the orthopedic stuff, I'm just not a huge fan in general. But we did PRP for a long time and stopped completely. Have not done PRP in quite a while. And what's funny is I tell patients, I say it's very lucrative. There are places out there, even today. Back in the day, it was, my gosh, but there are places out there today making a lot of money doing PRP. So you make a lot of money doing it, but I don't think it's effective, and I also think it can be harmful. So the reason why we really stopped doing it, it can provide some benefit in, like, a subsect of patients, very young patients with diffuse loss, female patients, a couple other ones. You can see some benefit from PRP. The problem with PRP is I believe, like you had mentioned, is that it is pro-inflammatory and it's pro-fibrotic, so it causes scarring. So if we think about what PRP is, so PRP is, for all intents and purposes, it's almost like a blood clot. It's platelet-rich plasma. Platelets are the elements in your blood that form blood clots. And the way PRP works is you take just a blood sample, usually it's your own blood sample, you spin it in a centrifuge, and it separates the platelet-rich area from the platelet-poor area. You then take the platelet-rich area, you inject it in the scalp, and then you're supposed to activate the PRP. And the reason you activate the PRP, and what activation means is you just basically break the platelets up. So you derma roll or you stab the scalp with a needle. Is because all of the growth factors in PRP, or most of them, are actually held inside the platelets. So you break open those platelets, they release the growth factors, and you get the benefit from it. The problem is that when your body is injured, so let's say that you cut your hand right now as we're talking here. One of the first things that's going to happen is your body is going to form a clot in that area, and in forming a clot, the body basically signals to just throw everything that it can in order to get that wound to heal. So
platelets, cytokines,
everything. Yeah. So clot formation is pro-inflammatory by nature, and it's very, like I said, non-specific. It's the body, when it comes to wound healing, is very non-specific. It doesn't say, like, Chris would benefit from using these inflammatory pro-markers, these cytokines, but not these ones. No, it just throws everything at it. So we know that platelets and clots basically are pro-inflammatory, and we know that they result in a scar, basically. So when you think about PRP, you're injecting something that's going to kick the body off to form a scar. Another problem with it is we also know that stabbing the scalp is going to create fibrosis and scarring. And if that's why I'm not a big fan of, in most cases, like the derma rolling stuff or the microneedling stuff, and I really advise against that in most patients. Yeah. But in order, and there are a few ways people say they get around it now, but in order to do PRP properly, you have to activate the PRP, and that means you have to stab the scalp, and that is going to cause fibrosis. So now you have something that, in and of itself, from a pathophysiological standpoint, is creating pro-inflammatory, pro-fibrotic environment. Number one. Number two, you're repeatedly stabbing the scalp, so that's just going to create scarring right there. And then another thing is that, in my experience, PRPs, it's fairly transient, it's fairly temporary. So you'll have patients that get a benefit for maybe 2-3 months, and then they want more of it. Yeah. So you bring them back, and now you're redoing the whole process. You're injecting the scalp again, you're stabbing the scalp again, and over time, all of that scarring changes the tissue and not for the better. You're replacing healthy skin and all the appendages like hair follicles with fibrotic, bad scarred up tissue. So I think over time, PRP is actually going to be a detriment. I really think that over time it's going to, take away tissue that has that good supportive fat, because fat is basically absent in scar tissue, and we know, like you mentioned, that you need fat for follicles to do well. Most of when you hear like stem cells in regard to hair, they're derived from the adipocytes, the fat cells. Yeah. So you're getting rid of that good healthy fatty tissue, you're replacing it with bad dead scar tissue. Bad dead scar tissue has bad vascular supply. Follicles need vascular supply to function. So I think you're making it worse over time. Another reason I'm not a huge fan of PRP is I do think that if you take a patient that has a lot of the diffuse loss, like where I said it does have some benefit, and you inject that stuff, you can really cause like a bad shed. And I think you'd mentioned you had maybe some bad shedding with it. And I've seen some patients that have had some really bad shedding. And you can almost get like a shock loss from it. And if those hairs are weak enough, they might not, come back from that. So long story short, we stopped doing it, not because it's not lucrative, not because you can't see some benefit in some patients, but because I think over time it's harmful. I think you're going to see not even like a net neutral. I think you're going to see a net negative in these patients that do enough PRP over time.
Yeah, I think that a lot of guys who are doing derma rolling, PRP, if if you're going to need a hair transplant, and that's okay. Like if you're going to need one, it's fine. But why would you want to destroy your scalp with derma rolling, with PRP? Because then you're making it less available for accepting of those donor grafts, right? So you're trying to plug a donor graft into a scarred area, which we know doesn't take. Even guys who get the strip, they'll have that strip put in with FUE, which is great. It can work. The first time, it typically goes around, but they don't take because, like you said, you're so scarred up, you can't accept the sub-Q tissue. It just doesn't accept it. It doesn't take as well.
Yeah.
I want to talk a little bit more about, jump to some medication stuff.
Okay.
So one of the biggest things, and kind of talk about what we're seeing now, what we've moved away from, kind of current medication recommendations for hair loss, any that you used to do, any that you are currently doing. The biggest rebuttal you and I have is a lot about 5-alpha reductase inhibitors and side effects and everything. So what are your current recommendations to maintain and regrow hair? So say someone hasn't had a hair transplant and they're coming to you and say, like, I don't know if I need one, but what should I do? I'm 25 years old. I notice, I'm starting to lose some hair, and where can I start? What's the best thing for me to start with?
So my sort of philosophy with hair loss medications, and we were just talking about this a minute ago, is, I think that you get really strong opinions both ways. You get people, and again, this is why some of the sites online can be a little bit crazy, but you get people that say if you're not, mainlining these hair loss medications, you're a fool. Other people say that, I touched a Finasteride pill in 1993, and I'm still having negative side effects. So it's really hard to get, to get that objective sort of opinion. So what I try to do with patients is I try to lay out just everything as factually as I can. These are the medications. This is the evidence, supporting them. This is, these are the potential issues you could have, and sort of what the research has shown. This is what I think it could do for you, and whether or not I think you'd be a candidate for it. Because some patients I just don't think are great candidates for medications, but most are. But in this scenario, where you have the 25-year-old guy, in my opinion, a 25-year-old guy is that's experiencing loss is a great candidate for medications. And that's because I personally think the biggest advantage, particularly of the anti-androgen medications like Finasteride, Dutasteride, is that they do a very good job at slowing the loss. Sometimes that slowing can be dramatic. Sometimes that slowing can last for decades. But you take a young guy that still has a lot of his own native hair, it can be such a powerful tool. So those are probably the ones that I recommend it, most thoroughly to. But as far as my recommendations, I always start with saying that these are the two that are, FDA approved. It's topical minoxidil, typically 5% for men, and oral finasteride, or Propecia 1 milligram. Those are the ones that the FDA have looked at. Those are the ones that they've said, we have reviewed the safety and efficacy, and we approve those. So that's what you're looking at there. As far as, kind of how, my treatment protocol has changed. So I always tell them that, and then I say, there are others, however, that and different forms of medications that people have used that are kind of similar, have sort of similar mechanisms of action or have similar efficacy, and a couple that always come into discussion. So the other one that comes up a lot, the topical minoxidil has been approved. A lot of patients have questions about oral minoxidil. oral minoxidil is a med that's been around for a very long time. It kind of has sort of these little blips of popularity in the hair loss, hair restoration field. But it's oral minoxidil has been around since before topical minoxidil was around, but it's become more popular recently. What I tell patients about that one is that from what I've seen, and there's not a lot of studies on it, but from what I've seen just anecdotally in my own practice, is that I think it's as effective as topical, maybe even slightly more. And I think that its biggest advantage is that it's a pill and not a topical, because a lot of people stop using minoxidil because they just hate the topical. Correct. It can irritate the scalp. It's a pain to put it on, especially twice a day. So that's an advantage there. As far as the safety profile, I have not personally seen a lot of problems with it because it's used at quite a low dose, when you compare it to what it was used for back in the day. It was used as a very, very potent blood pressure medication. Patients had like heart failure and things like that. But we're using it at dose anywhere between like 0.25 milligrams a day all the way up to 2.5 milligrams. I think that's low enough where the dosage is really not going to cause a problem in most patients. Having said that, and like I said, I like to give patients the whole picture. I like to be as independent as objective as I can. There have been some recent studies that have shown some EKG changes in young patients taking oral minoxidil, and that can be concerning because one of the potential side effects of oral minoxidil is changing cardiovascular stuff. I have not seen a lot of follow-up on that. I have not seen, whether or not this was clinically correlated with any problems. So, in my opinion, that medication is probably okay to use. I also think that, in a healthy guy, if you experience any potential cardiovascular side effects and you stop it, you're likely okay. So I usually don't have a problem recommending that one. As far as the other, sort of line of medications, the anti-androgens. Obviously, we talk a lot now about Dutasteride. Dutasteride is not a new medication either, but Dutasteride is a very, very good, strong anti-androgen. Dutasteride is going to be it's hard to say that it's not more effective, because if you just look at the numbers, you look at what it does, it is a more potent, more effective anti-androgen. And just to sort of step back for a moment, of the two classes of medications that are currently approved to do something with minoxidil and the anti-androgens are going to be your go-to because they're the ones that are going to slow this process. They're the ones that are going to lower and block those levels of DHT, the hormone that's attacking the follicle. So those are really going to be the workhorse. That's what you're going to want to be on. What minoxidil does, in and of itself, I don't think minoxidil does a ton. I think that minoxidil is good working in concert with the anti-androgens. What the anti-androgens will do is that they will take hairs that are very weak, they'll pump some life back into them, they'll get them to start growing longer, a little bit darker, and then minoxidil is almost like a boost. Like it'll take these hairs that are kind of like a little bit maybe vellus, a little see-through, a little weak, and it kind of gives them a boost where they're even darker, stronger. So they work well in concert together, but I think the anti-androgens are the better. If you're only going to be on one, the anti-androgens are the more effective of the two. And of those two, Dutasteride and Finasteride, I think Dutasteride is a stronger, I know it's a stronger medication. I mean, if you look at it, the studies and everything, and I don't know how much you want to get into those, I'm sure we will, but I think Dutasteride is a stronger medication. When a patient is on Finasteride and asking to switch to Dutasteride, what I usually tell them is if you're on Finasteride and you're doing well with it, maybe don't rock the boat. If I have somebody where they've been on Finasteride and they want to get off of it because of side effects, and I'm sure we'll get into that in a moment here, and because of that they want to switch to Dutasteride orally, I usually don't just off the cuff, or recommend that. But I do tell them is, look, there are different ways, that we can get that medication into your scalp. Topical or the mesotherapy, the injection. So there are other ways we can get that in there. So, maybe we shouldn't completely give up on anti-androgens yet because we could try injections, we could try topicals. So I have that conversation with them a lot. As far as if they're just telling me, which anti-androgen should I pick, I probably cater it to the patient, but I give them all the facts and I do let them know that, Dutasteride is probably the stronger of the two. As far as other medications go, I really don't recommend a whole lot of other things. I mean, I think there are some supplements,
Natural,
some things like that. It may do something, it may not. This industry is just riddled with people selling snake oil.
Exactly.
This is there's a lot of money to be made in the hair restoration, hair loss industry. You also have a whole group of people that are just devastated by their hair loss. And you could take the most informed person in the world. I've had doctors, in my office that are asking me about stuff that I'm just like, come on, man, that's not gonna do anything. But people are willing to suspend belief and try almost
Correct.
anything when it comes to getting their hair back. So you have just this army of used car salesmen. No offense to anyone out there that sells used cars, but you get what I'm saying. Who are just, they push anything and patients will try it. And so it's really difficult to recommend any of that stuff. I usually recommend staying away from it. Stick with either the two that are reviewed and approved by the FDA or ones that are very similar to that mechanism of action, so we know that they're gonna do something.
And from my own experience, I started with Finasteride and Rogaine, and I think it was like an uphill battle. The biggest things, and if we look at the research, I mean, half-life, Dutasteride, I've switched to Dutasteride since getting on, having my hair transplants. I will say from a physical feeling, Dutasteride, I just feel, I don't use any topicals anymore. I use, my stack is 0.5 milligrams Dutasteride, 5 milligrams, which is a higher dose of oral minoxidil. I have not had any side effects. And something that I tell people is, you might, anytime you're taking a medication, you might experience weird feelings. Give it about a week, see if they mitigate, or we can titrate up 1.25, 2.5 with oral minoxidil if you want to titrate up. But the feeling of both my donor and my top, it just feels stronger. I literally never shed. I used to shed all the time with topical. I shed all the time with Fin. And the biggest thing that I tell people is it takes time. You have to be on these things for a long time. And evidence shows that men who are on these for extended periods, the safety profile is great. Men will say, man, it's been 2 years, 5 years I've been on Dutasteride or Finasteride, and my hair feels better, it looks better, and they haven't had a hair transplant, they haven't done anything else. And I would say, personally, my hair feels stronger. I literally do not shed at all anymore, ever. It's like weird, there's no shedding, so that's my own personal experience. Everyone is different, but debunking a few things about, Dutasteride and 5-ARs, there's some misconceptions, specifically with prostate cancer and stuff. One of the misconceptions is taking 5-ARs increases the risk of prostate cancer. We know that claim does not supported by scientific evidence. In reality,
the opposite.
Yeah, exactly. Finasteride, Dutasteride actually reduce the size of the prostate. They inhibit, conversion of testosterone to DHT, specifically at that prostate. I know we're talking about hair, but the side effect of these drugs was we grew hair, so that's how we discovered this stuff. And then a lot of guys will say there'll be. Some other doctors will argue that there's high-grade prostate cancer, but in actuality, we're improving detection by taking these drugs for prostate cancer. So, you're shrinking the prostate, so detection is easier. So are we experiencing more prostate cancer, or are we detecting it earlier? Thus, those men who are already prone to it, who are taking a 5-AR, are actually detected earlier.
And I think that's always been the crux of it. I remember when I was working on the hair transplant network, when this study, like the initial study first hit, and people were freaking out. And I think that's the entire sort of crux of it, is that in reducing the size of the prostate, you're going to always make anything growing in there look bigger, look more aggressive. But I think that was the scientific community kind of did some more research on it and honed in and said, this is what's really happening. I have not seen anything since that study came out that said, no, this was correct, and there is a higher incidence of cancers and stuff like that. So. And
major studies show 5-ARs actually reduce the incidence of low-grade cancer without increasing the risk of high-grade cancer. Safety profiles, I mean, I have met one person who has had side effects from Finasteride or Dutasteride. That's it, one person. I have never had any sexual side effects. I have never, people say, brain fog. Brain fog, we know in research is caused by your diet. If we talk about post-Finasteride syndrome, that's another huge topic, which we know if we look at post-Finasteride syndrome, there's not much research supporting the data that it exists, and most research shows that it's the person's overall health. Are they diabetic? Are they obese? Are they low in testosterone? Usually some of that post-Finasteride syndrome, you're thinking, I took Finasteride, I still feel like crap, but you haven't addressed your weight loss, you haven't addressed diabetes, you haven't addressed your overall health. It'll mask itself as post-Finasteride syndrome. And another misconception is a lot of people think that I see it. Influencers will just be like, I'm losing my hair, I'm going to take minoxidil or Rogaine. I'm like, that's not. You're going to have a nice shiny scalp when you lose all your hair. Your donor is just going to look the same. But we have to block and stop DHT as best as we can to prolong that growth phase. So a lot of people don't understand that minoxidil is a great adjunct once you stop the hair loss, which again, I say to future clients is when you take these medications, I've been on them for, over 20 years, and I've never had a side effect. And I personally, I wish I had started and had known and done the research. I wish the research was out there to know that I could start on a 5-AR. I would have done Dutasteride, and maybe I would still need a hair transplant. We're not trying to put hair transplant surgeons out of business, but it's a great adjunct specifically after. I have a friend who's had hair transplants, and I said, that's great. You look great. Your hair is incredible. Great job. What are you doing to stop the rest of the hair that's on the top of your head? Because if you don't take a 5-AR, Fin, or Dutasteride, the rest of that hair is going to fall out, and you're going to be like, what the heck? My hair transplant didn't work. And it's not the surgeon's fault. It's your fault for not addressing the loss. The biggest thing that I also see is guys will go on Reddit, even some other networks, and they'll just be fear-mongered into the psychosomatic effects of Dutasteride. Like, oh, there's brain fog. And it's a case-by-case basis, I think, and you don't want to catch yourself on Reddit going down a rabbit hole of, oh, I have post-finasteride syndrome, I have this, I have that, because then you get so much fear that you have the nocebo effect, which we know is prominent.
Well, that's always, the side effects are the elephant in the room when it comes to medications. If these side effects didn't exist or potentially exist, you'd put it in the water, you'd throw everybody on, any guy that walked through your clinic door, you'd put them on these medications. But there's always, something I discuss with patients is there's always an argument as to what is the psychological and what is the physiological, because like you said, that whether you want to call it contagion, whether you want to call it Munchausen's, whether you want to call it just kind of giving into it, there's always going to be that strong sense that you can't break. If you go online and you read 50 guys where it destroyed my life, it's hard to shake that, and it's hard to take the medication to even get yourself to take it. It's hard to take the medication and then not also experience that. And what's interesting is in a lot of these studies that you've mentioned here, and I did a little more recent research knowing we were going to have this conversation. A lot of these studies, it's really fascinating because many of them are, double-blinded studies. So that both the researchers and the not enough of them are double-blinded, by the way. There's the research in this field is always lacking. But what double-blinded means is that both the researcher and the patient, they don't know if they're receiving a placebo or the medication. And what's fascinating is even in the placebo group, so the people that received, sugar pill for all intents and purposes, there was still like a large incidence of perceived sexual side effects. Some of these doctors came to the conclusion that it was higher in the actual, group that was given the medication, but still, like 10% of guys would be like, oh, I experienced sexual side effects when they were in the placebo group. So the side effects are always going to be the elephant in the room. It is unfortunate that the internet, for all the goodness that's out there and all the ways that I mentioned before, how it helps patients, is if you get on the wrong site or if you get, let yourself go down a rabbit hole at 3 a.m. on your phone, there is so much, I don't know if you want to call it misinformation, but there's so much of this like dichotomy, bipolar information where there's some people that are just so adamant about it and other people that are just so negative about it. So that makes it really difficult. And that's, again, I always try to give patients, as an objective point of view as I can on it. The conversation I always have about side effects is, in the initial finasteride studies that they've done, and then in some big follow-up ones that were done in Asian countries, Korea, Japan, a couple other ones, what they found was that the side effect profile specifically for sexual side effects was small. It was one study, I think the pharmaceutical company showed it was like 0.2%. Some of these other follow-up studies show that it's maybe as high as 2%. So quite small. But they also showed that when it was stopped, it reversed. I don't think they saw any incidents of these lingering long-term side effects for this post-finasteride syndrome. Other studies, and if you just go with kind of the general consensus on the internet right now, puts the incidence of side effects much higher. I've seen anywhere between like up to like 20%. I have not observed that clinically. I would say it's probably closer to maybe 10%. And then there's a a gradient. There's always nuance to this, which is what's missing online. Is patients said they had side effects. Well, what did you experience? There's varying degrees of what they could experience. And I've only had a few instances where I've seen patients in the clinic, and and I don't mean to belittle this or to dismiss these guys, but I have seen a few instances where patients were on the medications, they stopped them, and they still had the bad persistent side effects. And that's where you have to ask yourself if it is the physiologic, if these medications did something, or if it's the psychological, if it's just something where it's they cannot mentally get past this, and so it's having effects on the body. And then you also have to ask yourself, when we're weighing this here, what's the benefit that you're gonna get from this medication? So if you take that 25-year-old guy that it just has a ton of hair to hold on to, and you have a medication that you think is gonna really help, well, that's probably gonna tip the scale one way. If I have a guy who, let's say he comes into my clinic, he's a Norwood 6, which means he's slick, gone on top. And he maybe has, he maybe tells, a lot of people from the get-go say, I'm nervous about medications. You take a guy like that who I think is going to get very little benefit from a drug like Dutasteride, and I think may be, worried about it. That's probably, the scale is going to tip the other way. And I'm going to say, look, I would never discourage medications. If you want to give it a shot, I'm with you. I'll work with you. We'll make sure we get on a good regimen. We'll make sure that we stay in touch, and we're following this closely. But if you tell me I don't want to take it, I'm not going to be heartbroken, because I don't think it's going to do a whole lot for that guy. Another part of this conversation, I think, and this is why I think it's a lot of the topical stuff, which is can be controversial in itself, and the injectable stuff is so cool, because if you take a patient where, I think they'd benefit from something like a Dutasteride, for example, but maybe they tried Finasteride in the past and had side effects, or maybe they're worried about it. You tell them, look, there are different routes to get this medication into your body.
Mesotherapy.
And the reason why these routes have been investigated is because, what we've seen is that they get around a lot of the systemic side effects. The most common one are the topicals. And I think the topical right now is kind of like the Wild West of this industry, because everybody and their mother is making these topical solutions. They're throwing everything in them. And sorry if this sounds controversial, most of them are junk. They just are. And it's not because of the actual medical ingredients, it's because of the other stuff in there. It's very hard to get medication to cross the skin barrier. Just is. And it's even harder in the scalp, because the scalp is thicker and has more layers compared to the rest of the skin. So if you go to a company that advertises very heavily, and their model is based off just volume, they're not going to be taking the time to create a product that has what we call a vehicle, something that really effectively helps that medication cross the scalp. They're not going to put a lot of time and research into that, because it is an art. And I mean, there are PhDs out there that have dedicated their entire career to creating vehicles to help drugs cross membranes. So they're not going to be putting a lot of time into it, and it's not going to work. And it's funny, because I see a lot of these guys, and they tell me, they're like, and they don't even tell me, I can see it across the room. Their hair has this very odd, kind of pasty appearance to it.
And I was on top of it. Yeah,
it's because that topical is just sitting in your hair.
It's the worst thing. You doing it twice a day. You're it's 12 in the afternoon.
Yeah,
you're topical
I know.
Rogaine. You can't you're trying to figure out what do I do with my hair. It just looks like I look like George McFly with the greased slick back hair, because this is what it looks like.
A Back to the Future reference.
Yeah,
I wasn't anticipating that.
That's the first thing that popped in my head was George McFly at the
Yep.
dinner table laughing with his slick back hair, because that's what you look like when you put any of these topicals on. My recommendation, if you use a topical, do it at night after the shower.
Yeah, I agree.
There's no evidence. There's actually new evidence that shows it's just as effective to do it once a day. And if you're using Dutasteride, which has a great...
Something I love about Dutasteride, I got a 5-week half-life.
Yeah, so talk a little bit about that.
So
people don't even understand. This is why I say Dutasteride is better. The half-life, if you took one pill, it's 5 weeks that's in your system. Your serum levels, 90% blockage in your serum levels.
Yep.
70% with Finasteride, which is why, at Main and Steel, I advocate for Dutasteride. Even the side effect profile is better. But then if we look at mesotherapy, which is injectable, yes, that's going to cost you a little bit more. But if you don't want to take pills, if you don't want to do topicals, no matter what, you're going to have systemic effects. So if you have a systemic effect, meaning it's going to get in your blood, no matter what you're putting it in, it's going to get. But the effects are great, because it's 5 weeks, injectable 5 weeks. You do once every 5 weeks, maybe 4 weeks if you want to cut it off. Talk a little bit about mesotherapy and why that could be advantageous.
Yeah. So mesotherapy with Dutasteride specifically, something I really like. I think is really, really cool and interesting. And it's not that it's a new treatment. People have been doing it for a long time. But what's unique about doing mesotherapy with Dutasteride is the half-life of it, which we were mentioning before. So Chris was correct in that we basically said its half-life is when you put a drug in your system, it's how long it takes to break down until only 50% of it, which is probably below an effective dose is still in there. Most medications have a very short half-life. For example, Finasteride I think is 6 to 7 hours.
Yeah, I think.
Minoxidil, I think, is about the same. Dutasteride is 5 weeks, which is again, that's actually another conversation about how that could come into play with why you may have side effects with one versus the other. But we'll get into that in a different podcast here. But what's so cool about that is if you have a medication that has a short half-life, mesotherapy is ridiculous. You're going to bring someone every day and inject them. That's crazy. If you have a medication that has a 5-week half-life, that means you can do it once every couple months. You could do Dutasteride shots every 2 to 3 months and have it be effective. And the studies have shown, studies are crazy lacking with Dutasteride mesotherapy, but the studies have shown that it is quite effective. They've said that it basically, for almost everybody that underwent it in these different studies, that they had an increase in density and they had an increase in shaft diameter, so it's working. And they also said that in one study I saw in particular that 40% had like what they called like an extreme reaction or an excellent reaction or something. So I mean, it's working very well. So it's working. And what they also said was that none of the patients in these, and again, the research is limited, but none of these patients had side effects. None. I could not find a single incidence, which tells me that if you do this injectable Dutasteride properly, and it's a little tricky to do because of the level you have to inject at, but if you do it properly, it's staying there. It's not getting into because that's what causes the systemic side effects when it goes systemic. So it's staying where you inject it, and it's going to work for 5 weeks where you're putting it there. So that's why it's a very effective injectable treatment. But that's also why if you have a patient where you think they would benefit from an anti-androgen and maybe they've had a bad experience in the past, and you need to have that conversation. If someone's had a bad experience and you think they're going to have it again, don't bother. But if it's someone where they want to try it again, where maybe they would absolutely benefit, but they're hesitant to take an oral. The topicals or the mesotherapy is a great option to take because it is, from what we've seen, going to reduce the incidence and the chances of getting those systemic side effects. One last comment on the topical is, like you said, the topicals can be effective as well. There's a lot less research out there about them, but if they can cross the scalp, they should be effective. So look for ones where the science and the effort they're putting into it really seems high. One that I have spoken a lot with the chief science officer behind, and they've sent me some products and they sent me some research, is a real popular company called Zion. I'm sure you've heard of Zion. Zion does a topical Dutasteride gel. And of all the ones that I've seen so far, I think they've put the most time and effort into doing it properly. So I'm not saying you have to go with Zion or anything like that, but what I am saying is if you're considering a topical, you're going to be hit with, if you type in topical Dutasteride or something into Google, you're going to immediately be hit with the big marketing ones. And I won't name names, but it's pretty obvious the big marketing ones. In my experience, those just don't work. They're going to sit on top of your scalp. They're going to make your hair, look different, but that's about it. They're not going to get down there. If you're going to do a topical, look for one where you can say, I can tell that this is what these guys are specializing in. I can tell they're really putting the time in to develop this into an effective treatment. Or, I know it's not fun to have needles, but the Dutasteride mesotherapy, come in every couple months, get that done, and then you don't have to think about anything. You don't have to apply anything. You don't have to take any pill. It's done. It's in there. It's working and doing its thing. And I think the incidence of side effects from that's going to be quite low.
Yeah, shout out to Lars, who PharmD, great guy.
Oh, Lars is fantastic.
Doing Main and Steel's topical. Yeah, he is in genius. He's
intimidating.
We have it. Yeah, we have a great PharmD working for us. Yeah, we have a really smart guy who knows what he's doing, knows what he's like you said, who's really at the nitty gritty of how does it get into your head and how does it, how do we minimize side effects. 2 more things. Regarding FUT scar.
Okay.
I introduced you to CTM Biomedical.
Oh, yeah.
I know it's been, we're starting it. We're going to start using it more. Tell people about how we can help mitigate that scar with using growth factors. Stem cells is the big word, but talk a little bit about how using something like a growth factor of CTM can help minimize that scar and also help with future surgeries. Or specifically, can we start using it, as a adjunct to growth
So
in the scalp?
CTM's a product. So I'm very, very big on, new research, new products, things like that. Effective ones, obviously, and science-backed ones, but new products like that. So one of the ones that was brought to my attention was CTM. You had brought that to my attention. So what CTM is, CTM stands for connective tissue matrix or connective tissue membrane. And basically what it is, and there have been similar products to it before, but I think CTM does a really nice job with it. It's basically the extracellular matrix taken from other tissue of other people. And what the extracellular matrix is that is the sort of connective tissue entity that surrounds the cells in everybody's body. So everyone's body has cells, and they're not just kind of floating in the ether. They're sort of situated in this matrix. It's made up of things like collagen, elastin, blood vessels, things that add sort of rigidity and support and are very important not only in supporting the tissue, but also have a lot of that communication, that crosstalk, like I mentioned before. So CTM is a product that has human derived extracellular matrix in it. And one of the areas where it was first used was in surgeries. Specifically, they did it in like a lot of orthopedic surgeries, a lot of podiatric surgeries where not only did they want good wound healing down deep, but there was also incisions in the skin. They wanted to heal well. And what these big orthopedic guys were finding, and these I've seen a couple impressive examples in podiatric foot and ankle surgery, is that when they were done with their surgery, they would get this medication into the skin in a couple different ways. You can inject it, you can put down a paste, you can put down, I believe, even a film. Yeah. And what they were finding was very, very good wound healing. What the theory behind it is that you almost kind of trick the body. And this is something I've talked about with the drug verteporfin that I'm doing some research with as well. But with a drug like CTM, you almost trick the body because there'll be an insult, injury to that area, and the body immediately starts to flood the area. And one of the things that it has to rebuild when there's an injury and the normal tissue is gone, is it has to rebuild this extracellular matrix. And it does so in a very haphazard manner, and it does so in a manner that's weaker, and that's why the tissue is altered, why you get scar tissue. So when you inject normal extracellular matrix into a wound, the body is kind of told, like, hey, we're cool here. You don't need to flood it with all this profibrotic stuff, all this pro-inflammatory stuff. So it allows for sort of a slower, more controlled wound healing environment. And typically, in the end, that means better scars. So CTM had some excellent examples with orthopedic and a few other ones, but they were looking for some hair transplant, people to try it out. So I tried it out. My partner down in Florida, Dr. Rich Powell, tried it out. Initially, we were just doing it in the transplant scars. And I've been very impressed so far. I've done it on several surgeries down there with Dr. Powell, and I've done it a few times myself independently, and they're good. It's not a scar-free thing. It doesn't eliminate a scar. But I did it on one patient where I had done an FUT on him before, and he healed wider. He just naturally was a wider healer. And when I was doing a second FUT on him, he specifically was like, part of the reason coming in was scar revision. And I usually tell these patients that's not a great idea. We kind of either need to focus on revising the scar, or we need to focus on getting out tissue. Yeah. But with him, I said, look, I'm going to take out a reasonable amount of tissue. And I'm going to, if you are okay with it, I'm going to use this new medication, the CTM, and he's cool with it. Procedure is easy with it. And I've tracked him now for about 6 months, and, you can see his old scar versus new scar. I mean, it's much better with the CTM. The healing process seemed a lot slower and more controlled with the CTM compared to before. He didn't have as much of that big pink inflammation, the loss around it, stuff like that. So I think it's clearly working. The other patients out of Florida, have done well. They look really good. And it's funny, one guy, it was identical twins that I did surgery on. And one patient I did in New York, and I didn't use CTM. One we did in Florida, and we used CTM. And ironically, I have not seen the scar of the one brother we didn't use CTM on, but I've seen the scar of the one we used CTM, and it's fantastic. It's a great little strip scar. And we used it on one female patient, and I wasn't as impressed with that, but there were some compounding variables. But of what we've done so far with the scars, I think it's good. I think it's helpful. The other area where we're looking into it now, and Dr. Powell, if you're in the Florida area and you'd like a consult, not even for hair transplants, just to learn more about this stuff, he's just become a master at this injectable stuff. He's really passionate about it, and he's done even more with the CTM than I have. But we spoke with one of the chief science officers, Dr. Kelly Hyatt, who's a fantastic facial plastic surgeon, and she was doing a lot of not only scars with it, but she was injecting it into the scalp just to see if it would act almost like as a PRP. The mechanism would be very similar to a PRP, but I'll get into that in a moment. And she showed us some results that were impressive. And it's like, okay, let's try it. So Dr. Powell's been doing it down in Florida, and it's been pretty impressive. I would say that what I've seen from it thus far, and again, these are small samples. I would say it probably is on par with like a good PRP result, because you can get good results with PRP. I talked about some of the problems, but you can get good results from it. So it's probably on par with like a good PRP result. But what's good about CTM is that if PRP is pro-inflammatory, pro-scarring, CTM is the opposite. It's anti-inflammatory, anti-scarring. So CTM still includes all of what we call the trichogenic cytokines, so all of the growth factors that are going to make the hair better, like you see with PRP, but none of the bad inflammatory stuff. So CTM is something that you could probably use, and you're not going to see the negative effects that I've seen with PRP. It remains to be seen, but so far I've been impressed with it. But something I would mention is that I still would, if I had a patient where I think they'd benefit from CTM, I probably would try to talk to them about Dutasteride mesotherapy as well. Yeah. Because even if you're hitting those follicles with the growth factors, you're still going to need to
block that DHT.
You got to block the Persians from getting through the hot gates there. You got to be the Spartans. They're going to keep the armies there of DHT at bay. So I would encourage sort of a combination of the two. But what we've seen from CTM thus far has been pretty impressive.
Yeah, and kind of like you said, you got to stop that loss. So
yeah.
Get on as early as you can. Obviously consult first. Get on medication if you're suspecting loss. And we always say you won't realize hair loss until so much of your hair is gone.
50%.
50%,
yeah.
And then it's an uphill battle. I say this with my own experience. Start early. Get on medication if you have to. I'll post you can get on my Calendly, talk to me personally. If you don't want to talk to us, find your friends who are on medication. I tell people, get patients who have hair transplants, good hair transplants. Talk to anyone you can. Get off Reddit, get off some of these other forums. Find professionals, find people who have been in this space for a long time that are ultimately wanting to help you. And that's the overarching thing is, we're not in this space. Like, obviously, we create businesses, we go into hair transplant surgery, we have to pay the bills. But another thing is, I'm really passionate about seeing guys who are losing their hair, and I'm like, I can help you.
Yeah.
Even though I don't make any money off of selling you a product, if I can help you feel better and feel more confident, being like, wow, I'm glad I got a hair transplant, and the stigma behind it, do not be afraid to tell, I'm on Dutasteride.
Well, it's so different now than it was.
And that's one of the biggest things is like, it should not be what it was, 20 years ago.
Even when I started, like 10 years ago, there was so much of a stigma around it. And now, if I will give the explosion of some of this not great FUE any credit, it's that it's really brought the procedure to the forefront. It's really shined a lot of light on hair transplants in general. So I think the stigma of it has gone way, way, way down.
Yeah.
And there's even less of a stigma for using these medications, stuff like that. So
one of the biggest things I think that I see online is the influencers who are influenced themselves to go to a clinic that is just known for its advertising. And I wish more people would not be afraid to find a qualified surgeon in the United States. I prefer people to start with the United States if you're here, or Dr. Paresis in England.
In London, yeah.
Somewhere where it's actual doctors or healthcare practitioners who have experience in this field, which kind of brings me to my last question. Current state of hair transplantation in the U.S. So
in the U.S.
Okay. Are we in a state of flux with hair transplantation in the U.S.? Has there been any significant changes in recent years, techniques, industry practices? And what are your thoughts on the future for hair transplantation, particularly in terms of like newer surgeons? Because you and I talk about this a lot. What's changing, where are we at? Young guys who are in med school, look into hair transplantation. The lifestyle, it's a great field. Yeah. Lifestyle, you're not, it's very different. My father was a surgeon. I know what that life was like with my dad being a general surgeon. Technology, techniques, trends, new surgeons.
Yeah.
Final thoughts.
It's a good field. You can shoot podcasts in Orange County on a Friday afternoon.
That's true.
So we probably could do a whole episode on the state of hair transplantation in the U.S. And like you said, I agree that the quality of standards is very high in the U.S. But there are other good places. There are other places in the world where you can get good surgery, no question. But I think that was in reference to you want to go to a place that's doctor driven. But as far as the state of it in the U.S., I do think that it's a wee bit messy at the moment. What has happened is, if you sort of look at the history of hair transplants, probably about maybe 15 years ago or so, the field was a very specific, especially in the U.S., the field was a very specific, small field. It was tough to get into, and when strip was the predominant procedure, you really had to clear a lot of hurdles to have a good strip clinic. You had to have a big office, you had to have a big staff, you had to be comfortable with doing that procedure surgically. So if you went on a consultation with a doctor that said, I do a couple strip surgeries a week, you could be like, wow, that's pretty impressive. You'd be pretty confident that this guy was focused on hair. He had, had enough successful outcomes and produced enough good results that his business was propagating, and it was, it was a pretty safe bet to go to a guy like that. Now what's happened is, as time has gone on, I think one of the reasons why we've seen a shift in popularity from FUT to FUE, I really don't think it's because FUT produces such terrible scars, because I think that's, again, a whole other discussion, but I don't think that's the main reason. I don't think it's because FUTs is so invasive. I think one of the big drivers, not only these overseas clinics where the marketing has just become insane, but one of the other big drivers is that there have been some device manufacturing companies in the US that have decided, and I think they're kind of waning in popularity, but they decided to get into the hair transplant device industry, specifically making FUE machines. And not only did they try to make an FUE machine, they tried to make a turnkey hair transplant clinic in a machine. So what they would do is they would go to these doctors who, the salesman for these devices, they would go to these doctors, and they weren't going to clinics like mine or clinics like Dr. Meshkin's that did it the right way. Yeah. They were going to these general cosmetic guys or people that were maybe doing Botox, stuff like that, and saying, hey, look, you've probably always wanted to get into this hair thing. It's lucrative, you could do well in it, but you didn't want to train all those people, you didn't want to pay all that staff if you were an surgeon, you didn't want to have this big clinic, but I've got a solution for you. You buy this machine. It's either a robot that you go beep boop boop and it does the whole surgery for you, or the one that is more problematic is a device where they say you buy this machine and you don't even have to do the surgeries. Yeah. We give you results, by the way. Like that's something that's not talked about. As our company, when you sign up with us, they call it their procedure specifically. They don't say it's FUE through this device. They say it's our procedure. So they give you results to use. And when you sign up, and I've heard this story so many times now, for this procedure, you go to the office, you see a doctor, you think that's the guy doing the surgery, he says he's going to do it with this device. What they do is the company, when they sell you the device, they also sell you the service. So when you book in a surgery, they fly in technicians to non-licensed, medical-esque people, and these people do the whole surgery start to finish. Yeah. So FUE really started to rise in popularity in the US specifically because of that, because of these device manufacturers. So what's happened is you've seen a huge expansion in people doing that, and you've seen a very smaller, sort of incremental expansion, which is how it used to be, of people setting up clinics more like mine that were sort of like what they call like the golden age of transplants. And that's just because it's harder to do that. And it's much easier to say, well, this guy's going to sell me a machine, I'm going to get into it that way. So you've seen a lot of guys get into it that way. So that's sort of changed the dynamic. And I think it's really changed how younger guys get into it, because the younger guys now look at it and they're not going to see all the intricacies and nuances that I just explained. They're just going to say, everyone's getting this FUE thing. Why would I learn to do strip? Yeah. So I'm only going to learn FUE. So you have a lot of young surgeons coming up that aren't learning how to do FUT. You have a lot of the FUT doctors who are retiring because they're just, they're just older. So you have fewer people that can do a good strip. And you have more people that are just going into FUE and have never even learned, never even watched an FUT procedure. So that's been a big seismic shift. Because of that, we're seeing a lot more of poor FUE results. And that's not a knock specifically on FUE. That is a knock on people that are just getting into the business to make a buck and are not doing FUE properly. So we've seen a lot of that. As far as new like techniques or devices and stuff in the field, I would say there's probably not a ton. I think that hair transplant surgery, aside from some of these other cool little things we're working on to maybe like reduce scarring or, improve growth and things like that, but just the surgery itself has been quite good for a long time. As of now, we're at a point where, if you're a good clinic that uses microscopes, you can get those grafts down to follicular unit level, which is how hair naturally grows in the scalp. So if you're transplanting a follicular unit and it's cut down as small as it can, it really doesn't get much better than that. We're also at clinics that are capable of doing so, we're packing them in about as tight as we can. There's only so dense you can pack it in before the skin rejects it, and it doesn't do well. So if you are getting out as many grafts as you safely can, if you're cutting them down to follicular units and you're transplanting them densely, that's probably about as good as you're ever going to get with surgery. So I think surgery right now is quite good, and I don't really see it, becoming too much better. Maybe there'll be a couple little adjuncts that you could add on to make it, slightly more appealing or address a few of the sort of weaker areas of it, if you want to look at it that way. But I think surgery itself is pretty good right now. So do you have any other parts to that question? There was a multi-part question.
No, FUT itself, if you look at surgery hasn't changed. You're still using the same tools from 30 years ago, a scalpel.
Way older than that.
Yeah, the strip technique hasn't changed. The surgeon's skill has probably changed. Maybe what we use to visualize, and trained more, but FUE changes dramatically.
FUE, so like I kind of mentioned earlier, something that bothers me a little bit with FUE is that when they want to make the argument that, it's just a totally different ballgame than it was 20 years ago, it's really not. I mean, surgery. FUE is just using a biopsy punch, which have existed for forever. It's using a small biopsy punch to try to just get out a graft instead of getting out other tissue. I do think there have been some improvements in FUE that are actually improving the quality of it. And like I said, one of the guys that I give big props to, I think Dr. Feller did a lot, and I think Dr. Devois in Belgium, I think his WAD device was very clever. The way he not only sort of pushed for oscillation instead of pure rotation, but the flared out trumpet punch was very clever. So I do think that there's probably some benefit there. But the biggest improvement in FUE since it really came to the forefront was the ease at which the doctors can do it. It hasn't become much better for patients. It's become a lot better for doctors. And as far as FUT, it hasn't changed. It's a hair transplants is a very basic procedure, and I say that in a good way because you want surgery to be basic and step by step as a patient. I think what has improved with FUT is that I think we're coming to a point now where a phrase that I like to use a lot during consultations is something that I call FUT 2.0. And I didn't come up with that phrase. I read it in a journal article. I think it was Dr. Tykinzinski out of Brazil that came up with it. But basically, I think the point we're getting to with strip now is that we realize that it is a great technique and it can benefit a lot of patients. But maybe we need to cater it a little bit better to the individual patients. If a guy walks into my office and he's got extensive loss, of course it's going to be the most effective thing possible to take a strip from ear to ear as wide as I can and do that a couple times. But maybe he won't do that. So instead of that, maybe I tell him, look, let me just take a strip from the back, very back, because I found that a lot of patients have they psychologically have a problem when it wraps around the sides. It just bothers them. I get that. But I tell a guy, look, let me just take it from the back then. And then we could also augment with some FUE from the sides. That way we're sort of doing the best of both worlds. We're doing that good strip, we're getting out those high quality strip grafts, and I'll use those in the most visible areas, but we're not taking too much as an FUT where you're going to say, my gosh, now I don't like how it looks on the sides. We're also not doing too much with FUE where we're blowing out the donor. So you could always offer that. And then when you do that with a patient, what'll probably happen is during the next surgery, he'll say, the scar is fine, it wasn't as bad as I thought, can you just do it all the way around? Also, something I offer lots of patients is I tell them, look, I know you don't like the idea of taking out a continuous linear piece. I know you don't like the idea of a scar that's going to look surgical. What if instead of taking a full strip, I broke that strip up into smaller pieces and I took one here, I'll stagger them a little bit, I'll change the heights a little bit. That way I'm still getting out good strip grafts, but I'm not leaving one continuous scar. So even if people see the scars, even if down the line you say I'm going to shave my head, the scars look more like trauma. It'll look more like, hey, you fall off your bike as a kid and get stitches or something like that. It won't be like, oh, that guy had a surgery. Because FUT scars, people won't know it's a hair transplant, but it's a very clean, it looks like a purposeful incision, so people may think it's surgery. So I think that's a cool point where it's getting to. And I think you're seeing, there has been a big rise in popularity, and it's funny, if you look at Instagram and stuff, you'll see more of this, the FUT, FUE combos. And people that are trying to sort of modify FUT to say, hey, look, don't get rid of this procedure. It's really good. It's really going to help you. But, you know, we're not going to be so stubborn and say, you either do it this way where we're doing these huge, you know, FUTs all the way around, or you're not doing it at all. You know, maybe do this FUT 2.0 concept where you're really, you're like, look, you got to do some, you know, excisional harvesting, but let's do it a little bit differently so you're comfortable with it. And that way we're getting the benefits of it without any of the things that concern you. So that's a change that I've seen, something that I'm trying to kind of integrate a little bit more with regard to, you know, strip evolving. I
Maximize
suppose.
graft, preserve donor.
Yeah.
That's great. And I know I sound biased towards FUT. I think it's more so because of my poor experience. I'm not biased towards it. I mean, there are doctors who have incredible results with just FUE alone.
Absolutely. Yeah.
And if I could have the same results without the scar and I trusted FUE, I would probably just do that. But because of my experience, personal to me, that's why I chose to stick with FUT for my last one, hopefully. We're going to try and do maybe a little strip.
Yeah, I think we're going to do
and
a combo
go
with you.
The combo.
Yeah.
And I will try to film all that, record it as we go through it. We'll see. Other than that, this was awesome.
Yeah, this was great.
Thanks for flying in,
absolutely,
my friend. And thanks to the guys here at Sunset 17. We'll post all this hopefully within the next week or two.
Yeah.
But thanks, everyone, and more to come.
Excellent.
Awesome.